Thank you, Rick. Since I just have a few minutes, I just want to talk briefly about some of the barriers and facilitators to scaling up a treatment as prevention approach among sex workers. So we know globally that sex workers continue to have high HIV prevalence rates, both in concentrated epidemics as well as in more generalized epidemics, such as South Africa. And we also know that there's significant variation in HIV prevalence, both across and within regions, including by sexual structures and risk environments. This systematic review in 2008 looked at interventions targeting HIV prevention as well as prevention of other sexually transmitted infections among sex workers in both low and middle income countries. And the review really highlighted that while behavioral and biomedical interventions had modest impacts in reducing HIV incidence, really combined prevention approaches and multi-pronged approaches that included structural interventions were most effective in reducing HIV as well as STI prevalence. More recently, there's also been work looking at the cost effectiveness of interventions. In particular, this was a study in Dominican Republic that looked at how interventions that included both behavioral and biomedical interventions as well as structural support were most effective in terms of HIV prevention among sex workers. And perhaps what is the most well-known sort of broader structural as well as community intervention targeting HIV prevention among sex workers is the Sangachi model, which is highlighted as a best practice by WHO in West Bengal, India. And in this paper in Science, the results highlighted a 3 to 5-fold reduction in STI incidence among sex workers, where combining behavioral intervention with community mobilization as well as structural and policy support, as well as maintenance of a low HIV prevalence compared to neighboring communities. And while there isn't a ton of research on antiretroviral therapy initiation and adherence, I think the lessons that we can be learned from the HIV prevention and combined approaches, as well as some of the barriers, are really important going forward. In terms of the data that we do know in terms of effectiveness of antiretroviral therapy, we do see strong both effectiveness as well as uptake in certain settings. So this was a study in Mombasa, Kenya, that found that antiretroviral therapy was not associated with increased sexual risk among sex workers in a longitudinal cohort. And more recently, a study that's currently in press in JADES followed a longitudinal study following sex workers in Kigali, Rwanda, and found strong success in both linkage, so in both reaching out and testing, as well as linking sex workers to HIV care. And among antiretroviral therapy eligible sex workers who are newly HIV positive, the study found high rates of both initiation of antiretroviral therapy as well as positive treatment outcomes. So although they didn't have viral load data, they saw improvements in CD4 cell count as well as high adherence rates, so showing some important data showing successes of antiretroviral therapy among sex work populations. However, I also want to turn our attention just briefly to some of the barriers in really scaling up treatment as prevention approach and broader combined prevention approaches. This is a study, or at least a paper in The Lancet in 2000, that I think really echoes what some of the challenges we continue to face in really marrying a public health and human rights perspective in going forward. And certainly within the HIV context, this is in Cambodia, and in many settings, certainly HIV prevention continues to be hindered by sort of human rights violations and criminalization approaches. In Cambodia, condoms continue to be used as evidence of arrest for sex workers. We also see police rounding up sex workers and taking them to detainment camps. There's also been policies of sort of mandatory HIV testing in settings like Cambodia and Thailand, as well as other settings like Russia. And these evidence has shown that mandatory HIV testing policies have the result of pushing more marginalized sex workers and probably the most at-risk sex workers outside the public health umbrella. In this past October in Malawi, we also saw in the media substantial attention focused on the fact that police were rounding up and forcing sex workers to be HIV tested and then using that as a means of arrest. So certainly some caution points as we go forward in terms of approaches to HIV testing and treatment scale up and the need to really integrate more of the structural and policy approach. So I just want to conclude with some of the more broader methodological challenges as well. Some of these have been echoed in terms of discussions of other populations, such as injection drug users, but certainly the unknown size and boundaries of the population, much of that due to sort of criminalized nature of sex work in many settings, high rates of mobility and migration within the populations, as well as the need to really consider core and bridge population, in particular, the need to scale up efforts with clients as well as to consider overlap with other populations such as drug users and spouses within the general population. So thank you.